This presentation will cover the application of various sonographic techniques in evaluating patients with pelvic masses. Transabdominal sonography is used for a survey of the pelvis and in some cases can display images better than transvaginal. Transvaginal sonography allows us to see masses in detail. Color Doppler lets us depict the vascularity. 3D evaluates the morphology, and live 3D is a new technique which allows us to see the morphology of lesions. And I'll just mention, although it's not FDA approved, the application of contrast for evaluating patients with pelvic masses. I'm going to emphasize the clinically important parameters in evaluation of patients with pelvic masses, optimizing the use of these various techniques, and give you some examples. The clinically important questions are: is it benign or potentially malignant? Is it torsed? Is it persistent or transitory? Does it require immediate surgery or medical treatment? And if surgery is indicated, can it be performed laparoscopically? And these are all questions that need to be answered with ultrasound. Transvaginal sonography allows us to see detailed images of the adnexal structures, but color Doppler adds a lot of information concerning the vascularity of the lesion and its potential malignancy. Transabdominal provides a survey and overview. Transvaginal allows us to see details. Color Doppler, as I mentioned, evaluates the vascularity and the integrity of the vascularity. 3D allows us to see spatial relationships. In evaluating patients with pelvic masses, one needs to determine the organ of origin, whether it's uterine, ovarian, tubal, or other, such as related to bowel, whether the morphology is totally cystic, complex, meaning containing cystic and solid areas, or solid, whether the internal consistency is completely anechoic or fluid, whether there's septations or papillary excrescences. And finally, sonography should detect whether there's ascites, metastatic disease, or pelvochaliectasis. Now, I'm going to de-emphasize the evaluation of cystic masses because this is relatively straightforward. We need to determine whether it's a physiologic cyst, whether it indeed is related to the ovary or outside the ovary, such as para-ovarian cysts, and realize that some completely cystic masses can in fact be epithelial tumors. This Netter diagram shows the group of cystic lesions that we can study using sonography, and depending on where the ovulatory disorder occurs, we can have a follicular cyst or a corpus luteum or a luteal cyst if the hemorrhage has undergone fibrinolysis, for example. This is an example of a polycystic ovary with multiple immature follicles and thickened stroma, or whether or not there in fact is some leakage of hemorrhage in a hemorrhagic cyst. This is a very nice example, straightforward, of a normal ovary with a mature follicle and several immature follicles. This, on the other hand, is a hemorrhagic cyst. There's echogenic intraperitoneal fluid. On color, we can see the vascularity to this ovary, so we know it's not torsed, and we can see significant intraperitoneal fluid. In fact, when we watch this on cine loop, we can see that the fluid moves around. It goes back and forth. We can see the ovary, and in fact, we can see the fimbriated end of the tube, as we'll see here. And we know that this is fluid related to a hemorrhagic cyst. This being the fimbriated end of the tube. In postmenopausal women, it's not uncommon to see a smooth-walled cyst less than 3 centimeters, and these are probably inclusion cysts. Now, in a study which was done many years ago in follow-up of patients with greater or less than 5 centimeter cysts, you could see that some of these in fact disappeared in postmenopausal women. Some of them enlarged and some of them got bigger. In a larger study from Scandinavia, you could see that whether or not these cysts regress is related to age, with the younger patient having the more likelihood that cysts would regress. Now, the variation of cystic masses that we need to be concerned about are shown here. Ones with septations or papillary excrescences. These are typically epithelial tumors, dermoids, and we need to keep in the back of our mind that there's a variety of masses that have echogenic fluid in them, and that's dermoids, endometrioma, sometimes in mucinous tumors, and in patients with hemorrhage. The findings of malignancy are shown here. Papillary excrescences, only 50%, however, will be truly malignant. Some of these are borderline tumor, but thickened and irregular walls and clustered vessels on color are certainly findings suggestive of malignancy, as well as ascites. Now, this diagram shows very nicely what papillary excrescences look like. These are clusters of cells that grow into the center of the lesion and, in fact, can grow on the outside of the lesion. In these areas, there's abnormal proliferation of cells. Now, typically, unilocular cysts are almost always benign. However, ones with papillary projections, at least half of these will in fact be malignant. And here's some examples of small papillary projections. In this lesion, there's a small papillary projection along this wall, which has no increased vascularity associated with it. This, on the other hand, is a more complex lesion with large papillary excrescences and very abnormal vessels in this ovarian cancer. And as you can see here, some of the vessels have very low impedance flow. This is another example of papillary cancer, and you can see on this group of images the papillary projections. On 3D, we can see in this lesion some of the papillary projections beautifully, and here is a vessel going to this papillary projection. And as you can see, the blood flow in the papillary projection has very low impedance. Complex lesions are a group that can mimic each other: hemorrhagic cysts, endometriomas, dermoids, tubovarian abscesses. And dermoids can have echogenic areas due to sebum. They can have teeth, calcification, and of course hair follicles. Now, the more solid these are, the more likelihood that they indeed are malignant. As shown on the bottom of this image, this is a malignant teratoma. Endometriomas are typically these so-called powder burn lesions that occur on the surface of the ovary, or as shown here, or the uterus or bowel. The most common place for them to implant is in the uterosacral ligament. When they grow, they can become so-called chocolate cysts. Now, a tubovarian abscess typically evolves from a corpus luteum that has become infected, and as you can see here, multiple adhesions can form.